Opening prayer. In Jesus' name. Father, we thank you for today. We thank you for another year, another opportunity for us to gain more knowledge. Father, we commit today into your hand. We commit this module into your hand. Father, as we gather here because we want to increase our knowledge. We ask that you take total control in the name of Jesus. Father Almighty, we ask that everything we learn, we'll be able to put into practice for the furtherance of pharmacy and for the furtherance of our patients. Father Almighty, that at the end of the day, the people of Nigeria will be better for the knowledge that we have gained today in the name of Jesus. Father Almighty, we commit the speaker into your hands, that you will through her speak to us in Jesus' name. Amen.
Amen.
Okay. So our speaker we are going to jump right into the training session, and our topic today's module is module 8, and is the first module for the year 2021. The topic of the module is evidence-based clinical practice guidelines. So now, what are these clinical practice guidelines? We have a pharmacist who is going to be delivering the training. Her name is Dr. Mrs. Aderonke Olufunke OLOWU. She obtained her pharmacy degree from the Olabisi Onabanjo University. She has a Master of Science in Pharmacology from the University of Lagos, as well as a Master in Public Health from the University of Lagos. She is a fellow of the West African Postgraduate College of Pharmacists. She is a clinical pharmacist consultant. She has a Doctor of Pharmacy from the University of Benin. She has a diploma in leadership in health management from the University of Washington, and she's a certified genetic counselor. She's currently the assistant director in the Federal Medical Center in Ebute Metta. She's a member of MPSN. She's a member of Clinical Pharmacists of Nigeria, Lagos State Chapter. She's a member of the AHAPN. She's a member of ALPS, and she's also the treasurer of the West African Postgraduate College of Pharmacists, the Lagos Zone. So please, let us welcome Dr. Mrs. Aderonke Olufunke OLOWU as she delivers the training. Welcome, Dr. OLOWU. Of all of the modules we've had so far, from modules 1 to modules 7, we've had the introduction to the concept of drug information. We've had formulating an effective response, a structured approach. We've had module 3, drug information resources. We've had our module 4, drug literature evaluation, evaluation 1, controlled clinical trial evaluation. And module 5, literature evaluation 2, beyond the basics. We've had module 6, the application of statistical analysis in the biomedical sciences. And the last module we had at the end of last year is module 7, pharmacoeconomics. So now we are going to kick off this year with module 8, which is the evidence-based clinical practical guidelines. And our session is going to be taken by Dr. Olufunke OLOWU. So Dr. Olufunke OLOWU, we welcome you. The floor is yours.
Yes, Sister Anna. Thank you very much. Good evening, senior colleagues. Good evening, pharmacists in the house.
Good evening,
My name is Aderonke Olufunke, and I want to use this opportunity to say Happy New Year to everybody once again. As you know, our topic today is evidence-based clinical practice guidelines. I hope I'm audible enough.
Yes,
you are.
Thank you. So I'll be sharing my slides. So our objectives for this topic are as follows. We'll be looking at the definitions of two keywords, which is the clinical practice guidelines and evidence-based medicine. We're going to understand the philosophy of CPG and EPM, the importance of clinical practice guidelines and evidence-based medicine, the importance, the practice, the methods of developing these guidelines, and the standards for us to come up with a guidelines that is trustworthy. We're also going to look briefly at the tools of evaluating these guidelines, how to go about implementing them, barriers to implementing them, where we can get these guidelines, conclusions, and references. Definition. Clinical practice guidelines are recommendations for optimizing patient care that are developed by systematically reviewing the evidence and assessing the benefits and harms of healthcare interventions. Let's take it home. For every disease condition, there are several interventions that can take place. We can do surgery, we can do medicines, we can do non-pharmacological approach. Now, in different areas, different people use different methods. However, for us to have uniformity, we decide that there must be a guideline that is applied, that can be applied to all patients under care. And we are guaranteed of getting as close as possible a positive response. These guidelines are actually an offshoot of evidence-based medicine. So evidence-based medicine is just a philosophy of practice and an approach to making decisions in clinical care of patients. And it must involve the individual patient care. What do I mean? When you have a patient in front of you and you have been managing those patients and he has been responding based on the evidence you can see. The blood pressure was high, now it is normal. The sugar level was high, now it has been regularized. These are evidences that the method you're using to intervene is successful. However, in another client, in another area, in another zone, in another location, they might be using something else and there seems to be getting response as well. So everybody has different evidence-based interventions. However, for a clinical guidance, for a clinical practice guidelines, they must be able to bring all these evidences together, collate them, analyze to see which one will give us a better response, quicker response, with less resources. Like we said, it is just a recommendation. Evidences from every studies, from every practice are brought together, collated, analyzed, using different tools, then come up with a guidance. What are the importance of this? This chart is not very clear, but this is the JNC7 flow chart, which tells us how we manage certain patients on hypertension. It tells us that for a patient that is 18 years and above, this is what you do. It's lifestyle modification, which must continue all through the treatment. If there's no response, do this. If there's a response, do this. Is there a comorbidity, diabetes, do this. No comorbidities, do this. Is there a chronic kidney disease, do this. If not, do this. So it's a guide and a suggestions to the practitioner. But most importantly, the difference between that and evidence-based medicine is the beauty of it, I would say, is that clinical guidelines came out from evidence-based medicine. Then you are now using it back in evidence-based medicine, but you must be able to marry it to your patient on ground. I will expatiate more as we go. These are also guidelines from different, these are different clinical guidelines and they are being analyzed. You can look, if you look at it, you see what their own diagnosis of hypertension is. It differs from each guidelines. So everybody comes up with their own guidelines. Professional bodies, peer group, review, government, policymakers, physicians, pressure group, they all come up with their guidelines. So we as pharmacists, we are not supposed to swallow all guidelines. We are supposed to be able to sit down, analyze these guidelines, see if they are actually based on evidence, and adopt the one that is better for our patient per second, per client. What is the importance of these clinical practice guidelines? The primary attraction is that it is a summary of all current best evidence that works and does not when considering specific healthcare interventions. Take, for example, everybody is using methyl-dopa and is getting response. Then they started using labetalol, they are getting response. There's evidence that all these drugs work to reduce high blood pressure, hypertension. However, when you're going to come up with a clinical guidelines, the onus lies on you to compare the responses you have been obtaining from methyl-dopa to labetalol and see, looking at different tools, which one give a higher response, which one is sustained over a period of time. Then you cannot come out that, oh, we could as well start with methyl-dopa, but if you use it for so period of time and it's not effective, then you can go to labetalol. This would be a guide to the physician that, okay, I don't need to start from labetalol, let me start with methyl-dopa. However, if certain conditions are warranted, I might need to skip methyl-dopa and go straight to labetalol. So it's just it's just a summary of all evidences that are working and those that are not working. It also enhances communication between the physician and the patient, especially if the patient happens to leave one physician to go to another physician. On clerking and getting and establishing a robust professional relationship, you'll be able to see, okay, this is a trend that the patient is on. So definitely the previous physician is using these guidelines that you'll be able to follow. So there's continuity of care without necessarily starting all over again. I have here a little comparison of clinical practice guidelines and evidence-based medicine. Most times clinical practice guidelines are from secondary sources of information, of literature, while evidence-based medicine are from primary sources of information. I could as well say clinical guidelines are general, but evidence-based medicine is specific for a patient. It's tailored, is individualistic for a patient. Practice guidelines could be international, what works globally, but you must be able to adapt what works globally to your own local environment. If the recommendation is use ceftriaxone and your patient in your local assembly or your local area or your local practice cannot afford ceftriaxone, what do? You should be able to use what works in your environment. And then for antibiotics, there are trends, there are how do I put it? There are patterns in certain location. There are trends in certain location, which might differ from the global clinical guidelines. So the global clinical guidelines are just a guide, but you must be able to adjust it, adapt it to our local assembly. Clinical guidelines work majority of the population, while evidence-based medicine is adapting what works for the majority to my patient right there and right now. Another example is family planning method. Statistics have shown over the years that certain methods are more effective than certain methods. However, if in our region, the best, in quotes, method is not acceptable to their culture, to the preference of the patient, we cannot force them to use it. So that is why I said we have to be able to adapt, adjust our global practice to our local practice as well. Evidence-based medicine requires both clinical expertise. You must know what you're doing. And above that, you must be able to have an intimate knowledge of the patient, the situation, the belief, the priorities, the value of the patient. If you cannot marry the two, then I'm sorry to say all our knowledge is wasted. So whatever the guidelines say, you must be able to go a step further. And that is why we as pharmacists, we must be able to have a robust professional relationship with our clients, know them in total, know their likes. It's not like you give them the drugs and they are not going to take it. Right there and then, you will know from their body language if you are able to sell this idea to them or not. If you ask a patient to take a drug 4 times daily, and you know that you will not be able to, why don't you look for something that will give the same effect and is once daily or twice daily? That is where we differ from the physicians. We take the extra step to feel the heartbeat of our patients. External evidence must be used to inform, but not replace the individual clinical practice. So in your local practice, if you see you're getting a better result than what is recommended, but definitely is in line with the clinical practice guideline, then please, let's be free to use it. One of the goals of developing evidence-based clinical practice guideline is to help to speed up the process of getting evidence into practice. Many people are getting results, but because people are not aware, we are not sharing it in the body of knowledge. Nobody knows about these interventions. So when we have clinical guidelines, then everybody is able to bring in their own ideas from their corner of the world, and we're able to pull this together and come out with something that is robust, and we work with majority of the population. An understanding of evidence-based medicine is necessary for us to understand how to produce and how to implement these guidelines. In the practice of evidence-based medicine, 5 areas are looked into, and these areas are definitely linked together. The first one is being able to convert the information needed into a clearly defined, answerable clinical question. For example, there's a client, Mr. A, sitting in front of me. What is my goal? He has come in with a high blood pressure. My goal is to reduce the blood pressure from a certain level to a certain level. There must be a level attached to it. There must be a definition of the goal. It came in 160/100. My goal is to reduce it to 130/80. My goal is to reduce it to 120/70. I need to set a goal. So I've converted the information to a clinical question. How do I go about it? The second activity is for me to conduct a study to see what is the best thing I can do for this patient according to the guidelines: lifestyle modification, weight reduction, exercise, diet. That is the second line. Then the third one, I need to now appraise the evidences that I have before me, the clinical guidelines that I have before me. Is it doable? Is it achievable? As will result come from this? Has it been used and they get results previously? Yes. Good. This method will get me result of getting to my goal. But I need to incorporate it into the patient's unique characteristics. For example, those patient needs to exercise. Is a business executive, sedentary lifestyle, AC room, AC car, AC office, barely walk, hardly sweat. How do I introduce exercise for such person? For that caliber of client, I can introduce gym. Why don't you get a membership of a gym 3 times a week? You'll be able to network with other executives, business opportunity. I have introduced that guideline into a unique characteristic of my patient based on his lifestyle. But if he's a market woman, will I tell her to go and register in a gym? Would she be able to afford it? No. For her, I can advise her, if you are going to Oshodi, drop at Toyota, drop at 5-star, and walk the rest of the journey to Oshodi. Incorporating exercise 15 minutes into our daily activity. That means I'll be able to incorporate the global clinical practice guidelines into my own local, into my patient's characteristic. And finally, I must be able to evaluate the effectiveness and efficiency of these activities. That is what I call monitoring and evaluation. I must be able to monitor every step of the way to see if I'm getting result. If I'm not getting result, what can I do? If I'm getting result, how good is my result? And most importantly, this is a joint decision making with my client, with my patient. It's not for me to sit as a Lord and Master issuing out commands to the patient. I must be able to have the buy-in of the patient. Let us be partners in decision making. If you do this and you see the result, then everybody is happy. That is the beauty of evidence-based medicine. I started with this, I'm getting this result, which is a better result, a better outcome. My patient is happy, me, I'm also happy. Guideline developing groups. Not everybody is skilled enough to analyze primary literature. There's no denying the fact. As pharmacists, we are overwhelmed with so many activities. So the best thing at times is that we get a small, specially trained groups who I will be able to analyze these primary literatures. I have done the research. I found that intervention A works well. Somebody else said intervention B works well. Somebody is bringing intervention C. Then these small select groups, we bring all the results together, all the researches together, analyze it in terms of outcome, cost of treatment, duration of treatment. Other factors will be considered. They will now decide, fine, you're getting good results from the 3. However, number intervention A, we give a faster result at a cheaper cost than intervention B, than intervention C. Intervention C is good, but it's not affordable to the majority of the populace. So that would be a third option. So we need a select group of people trained to be able to develop guidelines from primary literature. It is a rigorous process. And that guideline is not specific for one patient. No, it must be able to be applicable to all patients, majority of patients, because we always have outliers. But majority of the patient must be able to benefit from these guidelines of, say, if we use this medication, instead of this medication, 80% of the patient will have faster resolution, non-recurrence, non-relapse, and the rest. And the guidelines should indirectly help, guide, motivate the healthcare professionals to develop and deliver certain types of care to people, not only to a specific patient. If all the guidelines we do is to just help 5% of the population, then it has failed. At least as essential medicine, it must be able to help majority of the population. What are the methods that we use in developing guidelines? We have to look at the methodology for clinical practice guidelines, and it is very critical for healthcare practitioners because they must be able to evaluate and implement these guidelines. And it is true because pharmacists are actually the custodians of drug information. We are positioned to be able to help the physicians, to be able to help the patients. We are like the bridge between them. So we also need to be well grounded in this. We should get involved in development of guidelines. We can start in our locality. What is the treatment? What is standard treatment guideline for malaria? Over time, we see that okay, the doctors prefer to use artemether-lumefantrine. No, they prefer to use diartemisinin plus piperacin combination. That is their first choice. Okay, in terms of severe malaria, what do they use? Artesunate, quinine. We'll be able to get a standard from the trends that they have been using. They will come back home and analyze what is the cost of using quinine as against using artesunate injection. What is the cost of using artemether-lumefantrine as against using diartemisinin piperacin? What is the cost? How soon does the patient come back for a relapse? How long does it take before he has another encounter with malaria parasites? Those are factors that we can look into. And gradually we're able to design a guideline for our own assembly, which we now compare with WHO guidelines in the management of malaria. It is very useful because the health decisions concerning health of millions of people will be used. These guidelines will be used in decision making. We cannot afford to make a mistake. We cannot afford to have bias. So in analysis of primary literatures, we must remove all bias as much as possible. A study that involves only males or only females, or the exclusion and inclusion criteria are not well defined, means that it is not a standard research. It's a random double-blinded trials carry more mark than just a patient walks in and I administer drug and I take the blood sample and I see the effect and I say, okay, this intervention is working. Remember that every guidelines, every decision, every advice, every recommendation we give to members of the healthcare team, the life of the patient is at stake. So we must make sure that we have facts to back up every decision that we are taking. For us to have standardized treatment guidelines, 2 committees have been formed by the International Organization of Medicine, and that's the Committee on Standards for Systematic Reviews of Comparative Effectiveness Research and Committee on Standards for Developing Trustworthy Clinical Practice Guidelines. These 2 committees are charged with the responsibilities, and there are 8 steps in coming up with these guidelines. The first one is to establish transparency. If a certain pharmaceutical industry, I have a business understanding with them to promote their products, then I'll be biased in making guidelines. So I must ensure that there is transparency. Where am I getting the funds for the guidelines? Where am I getting funds for the research? So when we have different primary literature, we must look at the source of their funding. Are they funded by pharmaceutical industries? Because that has a way of giving bias in the results. What are the caliber of people involved? Those are the things we need to look into. What is the conflict of interest? Have I carried out a research before? Do they give me grants to carry out researches? Then it's payback time. I need to protect their products. Then I'm going to make sure that every guidelines carry their drug as first-line treatment. So we must be able to make sure that there's transparency. We must be able to make sure that there's no conflict of interest. And if there's conflict of interest, we must be able to manage it. Conflict of interest does not necessarily have to be financial. It has to be intellectual property as well. If I've carried out a research that the standard treatment guidelines or the best evidence I'm getting is from artemether lumefantrine, for example, and on evidence-based, comparing from other studies from everywhere, is showing that another brand of ACT is going to be more effective. Because I have published, because my face is known with artemether lumefantrine, I might try to suppress. That's an intellectual conflict of interest. Then for us to develop a clinical guideline is a multidisciplinary group. It involves a lot of professions. It's not just the pharmacy things. We need a lot of people that are going to be involved in coming up with the clinical guidelines. Then we must be able to conduct a systematic review for qualifying evidences. All researches must be subject to uniformity so that we get the best out of them. They will be able to establish evidence foundation for and rate the strength of the recommendations we are giving. Articulate recommendations. Most times we refuse to document, or we do not document properly. We must be able to articulate, document our recommendations. We must also be able to conduct an external review. Okay, we have come out with this information. We can give it to an external body that has nothing to do with these people, independent body to review, so that they will be sure that there's no bias and we have come up with the best as at that time. They will establish a plan for updating the guidelines. The body of knowledge is expanding every day. And a typical example is the management of COVID-19. over the last 6, 8 months, 12 months, different therapies, different suggestions, different protocols have been coming up. So for every guidelines, there must be a plan to keep updating them in line of new evidences. What is the best today might just be good tomorrow. So we must not relax on our house and think that we are at promised land. No, every time there's knowledge. So as pharmacists, we must keep educating and improving ourselves. Thank God for opportunities like this for us to keep encouraging and developing ourselves. The process, okay, we've talked about establishing transparency, which tells us that where is a fund, you must explicitly say it. Where are the funds coming from? Is it from is it a grant, a Greek gift? You must be able to say it, because that is where the body of professionals will be able to buy into that idea. If it's a Greek gift, then it's going to be tainted. It also helps us to understand who made what. Who are the caliber of people involved in this research? What is their clinical experiences? What is the potential conflict of interest? You must be able to manage the conflict of interest, like I mentioned earlier on. Most times, we cannot help but have relationship with pharma industries. We cannot help it, but we must be able to manage such relationship in line of better evidences. If you're going to be so strict that anybody that has a conflict of interest or an interaction with certain pharma industries that have certain products should not take part in the clinical guidelines, then we will not be having a robust guidelines, because there are some disease state that we need the expertise of those people. For example, in the management of cancer, most likely big pharma industries are the one sponsoring the research on cancer, on oncology. And then this is a well-known professional expert in this field. Would we deny ourselves the use of his knowledge because he is being sponsored or he has grant into the research of oncology from a certain pharma industry? No. However, there will be restrictions. When it comes to final decisions, such people will not be involved. You can do all the preliminaries, but the final result analysis will now be handed over to independent analysts to come up with. The third step is we have to establish a multidisciplinary guidelines. Like I said earlier on, it's not a one profession thing. It cuts across. The physician with the expertise of the conditions, the care disciplines, the pharmacists, the physiotherapists, nurses, occupational therapy, dentistry, all those ones need to come in with their own ideas as well to help. We also need patients that are involved, patients of that disease state. There also needs to be involved, or their caregivers. We also need people like that have editorial ability to help us craft the outcomes of these results, of this evidence. The ability to conduct a systematic review to qualifying evidences. You must be able to select an appropriate topic for creating a guideline, define the clinical questions to be addressed, determine the study screening selection criteria, conduct the systematic research, critically appraise individual studies, and synthesize the body of knowledge. When you are creating a guidelines, there are some things you need to look at. The disease state that you want to look into must have a high prevalence, affect majority of people, high frequency or severity of associated morbidity or mortality, and there must be availability of high quality evidence for the efficacy of treatment that reduce morbidity or mortality. That yes, when we use this intervention for this, we see better results. Then it is time that for us to come up with the guidelines so that we don't work in the darkness. We don't continually lose patients because we are trying to experiment. Let there be a guidelines, let us follow these guidelines. Feasibility of implementation. Can they afford it? Can we implement it? Will the patient be able to afford it? What is it cost effective? If there's a better alternative, but is beyond the reach of majority of the patient, then there's no point. They must be able to say that the current practice that we are doing is not optimal. We can get better results. If an intervention is giving us 50% recovery rate, and another one is offering us 80% recovery rate at lower cost, for example, or a marginally higher cost, why won't we go for the one that will offer us 80% cure rate at a little, I'm paying a premium, just a little above. Also, we should look at the availability of personnel, expertise, and resources. There are certain researches that show that guidelines that is working wonders. We are getting good results. But here in Africa, here in the resource limited countries, we don't have the equipment for that. Then what do? We might as well still keep using our old and reliable when we don't have resources to get the new improved version. An example of this is a guideline for cardiovascular disease prevention in women. It was developed because we saw certain things. Cardiovascular disease is the leading cause of death for women in the United States. When I saw that more women are dying of cardiovascular disease, then let's look at the guidelines to prevent this. And they know that coronary heart disease can be prevented, but once you prevent it, then majority of women will not die suddenly. We are able to review and develop strategy for prevention of coronary heart disease in women. When we saw the result from the Women's Health Initiative and the heart and estrogen progesterone replacement study, all the results from this study shows that if you're able to control certain things, then we have less women coming down with coronary heart disease, then less women are dying. Then they were able to come out with the guidelines for this. The strength of recommendation. This step focuses on getting a result. The evidences are there. We've agreed. The grading of recommendation, assessment, development, and evaluation working group, they now develop. At the end of all the analysis of all qualified evidences, we come out with recommendation. It's either you have a strong recommendation for using an intervention that based on all information at our disposal, then we recommend this intervention. Or say there's a weak recommendation. No, we cannot use this recommendation. It's weak. Even though they are getting 1 or 2 results, there's a better way of going about it. The weak recommendation against an intervention is like, well, it's still manageable. And there's a strong recommendation against an intervention. No, we should not use it. And what are the factors they consider in reaching these recommendations? There must be a balance of the benefits to risk. If the benefit is higher than the risk, then we can give it a strong recommendations. The quality rating of the evidences. Are we sure that there is no bias? Every confounding factors have been removed. Variability in the values and preferences that may occur between different patients in different circumstances, and the resource use implications. If we don't have the resources, no matter how beautiful the idea is, we cannot use it, or it's only for the selected few. Then we must be able to articulate our recommendations. When we have a recommendation that is strong recommendation, then we should mind our languages. Then we can use something like we recommend, clinicians should. But if it's a weak recommendation, we could use sentences like we suggest, where clinicians might or clinicians may. That shows that it is a weak recommendation. But when we are 100% or almost 100% sure, we can say things like we recommend, clinicians should do this. Then when we are writing this format, there are different formats. There's a detailed ones that show the steps that we took to arriving at these guidelines. And there's the abridged version that for quick references, let's quickly look at it. And there are some that are patient-friendly. Those information that we give to the patient that they can use will not be too technical, it will not be too wordy, it will not be too highfalutin that the patients cannot understand. So when you have a guidelines, there are different versions to it. And good thing is that it will also come in shapes of organogram so that we can go step by step into it. Conduct an external review, very important. we are able to give it to independent bodies to review, and then we get a feedback from them. And very importantly, we must document this step. And finally, we must establish a plan for updating the guidelines. The body of knowledge keeps revolving every day, and we must be on our toes to update our knowledge as well. Quickly, we will go to the guideline evaluation tools. One of the important tools we use is the appraiser of guidelines for research and evaluation, AGRI collaboration. This is an international group of researchers and policymakers. This collaboration has produced a structured instrument which can be used for critical appraisal of clinical practice guidelines. And it has refined an instrument which we call the AGRI-2 instruments. The AGRI-2 instrument have 23 quality items under 6 domains. These 6 domains are scope and purpose, stakeholders involvement, rigor of development, clarity and presentation, applicability, and editorial independence. And we have these 23 items. We have global ratings on the point of 1 to 7, strongly disagree, strongly agree. These are scored. These evidences are scored. These guidelines are scored based on this instrument. I will now come out with the fact that this is highly recommended or not recommended. Implication of clinical practice guidelines. From all we have said, we know that these recommendations will, in most instances, be able to help us in the management of a patient from A to Z. If followed, because body of evidences has shown that each of those interventions has been put in practice in different areas and have come out tops. So it is always very good. If I'm meeting the patient for the first time, it gives me an idea on how to manage this patient, especially where they say where there is no doctor or where healthcare facilities are far away. They will be able to manage successfully on if there is no complications, no comorbidities that is beyond our management. However, there are some things that help us to monitor or implement this. Institutional, organizational, and local practice. If the institute says this is how, institution says this is how we want to manage malaria, for example, then everybody will follow that protocol. The local practice is how they have been doing it. It's easier for them to buy into the guidelines. There are times the individual practitioner feels that this is how I want to do my own, then he continues in that way, despite the clinical guidelines. Some things affect implementation.
It seems Dr. Olufunke is having some network issues. Hopefully she'll be able to join us soon in order to conclude her training session. In the interim, I would like to recognize some pharmacists in the house. We have Dr. Bola Olaiwola. We welcome you. We have Professor Jamilu Muazu. We welcome you. We have some other, I want to welcome and thank everybody present at the training session. Thank you for your presence here. And I hope that we are all gaining a lot from this training session. I don't know if Dr. Olufunke is back. She's still not back. She's still not able to connect. So while we are waiting for her to connect, I'm sure some of you will have some questions. Please put your questions in the chat room so that she'll be able to address your questions and answer your questions once she's back on and she has finished her training session. I also want to recognize Professor Ismail Suleiman. You're welcome, sir. So like I said, if you have any questions for her, and I'm sure if you have any question for her, and I'm sure some of us would have questions for her, please write your questions in the chat, and we'll give it to her so that she can answer your question. So a quick recap of what she has said so far. She has given us the definitions of clinical practice guidelines and evidence-based medicine. She has also told us the importance of clinical practice guidelines. She has told us the differences between clinical practice guidelines and versus evidence-based medicine. One, we have the secondary sources versus the primary sources. Our source for evidence-based medicine is usually primary source. For clinical practice guidelines, secondary source. Evidence-based medicine is usually specific, while clinical practice guideline is general. Let me see if she's back. Oh yes, Dr. Olowu is back. So Dr. Olowu, please continue with your session.
Thank you. The network threw me out. Nigeria factor.
That's fine.
All right. Sorry for that. So we're talking about the barriers to guideline implementation. And we said one of the reasons was lack of awareness. We do not know it exists, or lack of familiarity with it. Most times we see it bulky and we just don't want to go into it. But as pharmacists, I want to encourage us that even if it's the quick references one, let's get familiar with guidelines. Guidelines for management of cough, guidelines for management of upper respiratory, guidelines for many things. Let's get familiar with them. We'll be able to talk with authority and with confidence. Lack of agreement could be one of the reasons, the barriers to implementation. The care provider will just believe that no, these guidelines, I don't believe in it. I've been using my good old chloroquine and I'm okay with it. Just don't agree. The lack of self-efficacy. What's the point? I beg, let me just do what I have to do. Lack of outcome expectancy. I do not even have an expectation of the goal. There's no measurement, there's no comparison, there's no baseline measurement. Then there's no point going with guidelines. We're just treating blindly. Inertia of previous practice. This is how we have been doing it. Look, I cannot change. Old dog does not change his habit. No, we must be up and doing. And then there will always be external barriers as well. Where are the sources of clinical practice guidelines? Websites such as the National Guideline Clearinghouse. You could also Google guidelines for the management of COVID-19, guidelines for the management of, okay, there's no guideline for COVID-19, it's just protocols that we have. Guidelines for management of severe malaria in pregnancy, guideline of managing preeclampsia, there are guidelines for every conditions we can talk about. As pharmacists, we can now look at those guidelines and assess them. What are their primary sources of information? Who are the authors? What is the disclosure? Is there transparency? Is there, what is the source of their funding? We could now look at it in view of this lecture of today, this training of today. We cannot take a guideline and now critique it and come up with our own conclusion as individuals, as professionals. And we can get these guidelines from website. We can get it from peer-reviewed literatures. We can get it from libraries such as the Cochrane libraries and the rest. Just go online, we'll get it. In conclusion, guidelines have the potential to assist medical decision-making and ultimately improve the quality of care, improve patient outcomes, and make more efficient uses of resources. These are key factors in guidelines development. We're able to manage resources. We're able to get more results from limited resources. Patient outcome is better. Quality of care is top-notch. Significant advances have been made in method of producing valid guidelines. Just as we have discussed, there are steps, there are committees, there are tools that are used to analyze even every guidelines that come out. So before a guideline is eventually published, it has gone through a rigorous process that we can go to sleep and say, yes, this will work for my patient. Just a little twist to meet my own local flavor, it will work. Pharmacists' active involvement in preparation and implementation of evidence-based clinical practice guidelines is vital. It is high time for pharmacists to take charge. I remember just this week, AHAPN in Lagos was having a meeting, and there was a company that came in for presentation. And the conclusion is, you people will do clinical trials and you don't involve the pharmacists. Well, they said they have been doing clinical trials involving pharmacists. This is time for pharmacists to talk to the company reps, to talk to the pharma industry, to talk with our colleagues in the industry. When there's going to be clinical researches, when there are going to be clinical trials, involve pharmacists. Our roles cannot be underestimated. Our contributions is vital. We are the custodians of drug information. Most times we shy away because we feel we don't have the confidence, we don't have the technical know-how. But when we start in our small corner, when we start in our little way, analyzing guidelines, getting familiar with guidelines, we increase our confidence and we're able to talk confidently and add to the body of knowledge. We earn our place of respect. A thorough understanding of evidence-based methods will prepare the pharmacists to participate in this process. So we expect that after this, we'll be able to talk confidently and handle researches and analyze and tear evidences, literatures to pieces and put them back together. Drug information trained pharmacist is an ideal person to help prepare and implement evidence-based practice guidelines. Are we ready? We are drug information specialists. We are ready. Thank you very much. God bless us.
Thank you very much, Dr. Aderonke Olufunke. That was a very highly informative session. You have stirred us and challenged us, and hopefully from this moment forward, we will realize our role and our places as drug information specialists, especially when it comes to um, evidence-based medicines and clinical practice guidelines. Thank you very much.
Thank you.
So we're going to go straight into our question and answer session because of time. So if you have any question for Dr. Olowu, please put your questions in the chat room or raise your hands and I will call you. And when I call you, you'll be able to ask your question. So please, I'll be checking now to see if anybody's hand is raised. Please, if you have any question for Dr. Olowu, please raise your hand. Indicate by raising your hand, and I'll call you. Or if you can put your question in the chat room. Thank you. I'll give us 1 minute to put our questions in the chat or raise our. Okay, so there's no question in the chat room, and I'm not seeing any hand raised. Okay, let me see. Okay, so no question in the chat room and no hand raised. So I'm going to believe that everybody especially since you gave us live examples, I'm going to believe that everybody is clear on the information we've gotten. Those live examples have been able to help us in understanding our evidence-based medicine. So thank you very much, Dr. Olowu. You have really done a great job. And I also want to thank everybody that has been here for the lecture, for the training. I hope everybody has is clear, has received um, a, um, a lot of knowledge and information from this session. So in the light of no questions, and I want to say again, thank you, Dr. Olowu. God bless you. You have really done a great job. So I'll quickly hand over to pharmacist Ibrahim Bello for just a quickly a word or two. Then we can call the training session to a close.
Okay, thank you, Pharmacist Okame, for that good one. I want to congratulate Dr. Aderonke Olufunke for that great job. It was an excellent one. We are really informed and educated. We thank you for that. We thank you. We thank you. It's a very good one, a very good job. So I want to say that in the next 2 weeks, we're going to have another one, and it's going to be on Module 9. I want to call on the people involved to start preparing. 2 weeks is not far away. It's so close. So if you start preparing now, you're going to have another beautiful section as like you had today by Pharmacist Aderonke Olufunke. That's my message for the people that we're having in the next 2 weeks. That is a Module 9. It's going to be on Journal Club. So let us prepare and meet again in 2 weeks' time by God's grace. We thank you all for coming. For those who took that time to participate, I know your time is not wasted. Pharmacist Olufunke has done justice to the topic today. We are highly educated and highly informed. Thank you, everybody. That's my contribution. Thank you.
Okay. Dr. Olowu, apologies, but somebody has sent in a question and we would like if you can answer it. Will that be fine? Dr. Olowu?
Yes, you handle it.
Okay, so the question is, where do we get funding for developing guidelines? The person wants to know how funding for developing guidelines can be gotten.
Sorry, we lost again. Oh. I think she has a network issue again.
Yes, I think so.
Yeah.
The person that asked this question, if we're not able to get her back from the as as a result of this network issue, we will transfer the question to the platform and for her to respond on the platform. So we will just give her maybe a minute to see if she can reconnect back, and if she's unable to reconnect back, then we will transfer the question to the platform, and hopefully she'll be able to answer the question there. That's Dr. Jimo Kamu from Liberia. So we'll transfer your question to the platform. If she's not, she doesn't connect back in at least a few seconds more. Let me just give her that. Okay. Let's what I would suggest is that we close the training session, and then I transfer the question to the group chat, because she might feel we have ended the training anyway, since we're rounding up when she lost network. So I want to thank everybody for attending this training session. I hope you'll be able to use this knowledge, like I said, to get the best for our patients. Thank you very much. Good night, everybody.
Good night. Thank you, Dr. Okame, for that one. We see again in the next 2 weeks by God's grace.